Good afternoon, everyone, or good evening. Thanks for joining us today in this webinar, Living with ROS1 Positive Lung Cancer, organized for the Florida Society of Clinical Oncology. My name is Raez. I am a medical oncologist, thoracic oncologist at Memorial Cancer Institute here in Brevard County in South Florida. I am past president of FLASCO, and I serve as tonight moderator and keynote speaker. I'm very happy to have very good speakers with me tonight. We hope that you enjoy the program. The Florida Society of Clinical Oncology is a member-driven organization that supports oncology professionals by providing education, resources, and advocacy. That's why we do this type of events. We collaborate across all disciplines, and we empower clinicians with education, tools, and support to advance care. From championing research and providing education to navigate the current challenges in oncology care. FLASCO is a trusted partner in fight against cancer, ensuring the highest quality care for patients across the state. Each of the members presenting here today are part of this incredible society, and they are also friends, and we have guests from other cancer centers in the United States. And we had very happy to devote our time and expertise to support our patients and our caregivers. First of all, I want to give thanks to our sponsors. Tonight, our sponsors are Nuvation Bio, the go-to foundation for lung cancer, and the ROS1, the ROS Wonders, our group of survivors and caregivers with ROS1 disease. Thank you very much for supporting this webinar and this education initiative. I also like to let everybody know that this webinar is being recorded, so for the people that has been unable to attend, this will be available, and you can watch anytime. At the same time, if you find it interesting and you want to see it again, you can do it in your own time. At the end, we want to have 4 presentations, and at the end, we're going to have time, like at least 20 minutes for Q&A. So please, we encourage to send questions in the chat. So at the end, we will ask to all our panelists, or we'll comment together. So we always are very happy to answer questions from our patients or our advocates. So that's why please don't be shy to doing so. That's what we are putting in the chat. So it's easy than doing the chat than asking questions directly by Zoom. Okay, so without more delay, we are going to start with our first speaker, Dr. Martin Dietrich from Cancer Care Centers of Brevard. He's a well-recognized lung cancer speaker. He's going to talk about what is ROS positive for lung cancer. Martin.
Thank you so much, Dr. Raez. Good evening, everybody. It's so nice to be with you tonight, and a little bit of an overview of our work in non-small cell lung cancer and ROS1 positive disease. I'm Martin Dietrich. I'm a medical oncologist with US Oncology in Orlando, Florida. And we're working on a genetic definition of non-small cell lung cancer. This was really the next layer of deep understanding of how non-small cell lung cancer can be tackled, and was, in fact, the first subset of solid tumors that was able to be dissected slice by slice into different genetic subsets that provide unique opportunities for treatment, and ROS1 obviously being one of them. But I do want to keep it a little bit broader before my colleague Dr. Rotow is going to dive a little bit into the treatment landscape of opportunities here, which are obviously very nice. It's always a very good correlation between understanding the biology of a cancer and unraveling treatment opportunities. So I'll be sharing some of that. Obviously, non-small cell lung cancer, just by the name already, sort of an antiquated definition. Non-small cell lung cancer really describing how cancer looked like under the microscope. And we dissected this further over time into subsets, but we really need to understand it at the very heart and core of it for best treatments to be available. So when we think about the journey of a non-small cell lung cancer treatment, it really starts with a comprehensive evaluation upfront for diagnosis and treatment. And this is particularly important as non-small cell lung cancer is by far the most common of the big cancers in terms of cancer-related mortalities, about almost 250,000 cases a year. So this is incredibly frequent, and we're seeing the face of lung cancer shifting, but not necessarily decreasing. We're a little bit better in sort of the smoking cessation efforts that are blending in, but we still see a significant amount. And obviously, with air pollution and other environmental exposures, we see a new phase of lung cancer emerging in patients that may have never smoked, in patients that are younger, oftentimes in more vulnerable patients, oftentimes younger women. So an important part. So this is really a shift from the original division of lung cancer into small cell and non-small cell lung cancer, simply a size division by how cells look like, into more distinct subsets. As you know, lung cancer has screening opportunities available, but unfortunately, some of them are underutilized, and some patients that may be at risk are not eligible based on the current criteria that we have. Those are typically patients between 50 and 80 years with at least a 20-pack year smoking history, meaning smoking 1 pack per day for 20 years. Many patients are below that. They're outside the age range. So unfortunately, about half of our lung cancers are diagnosed in distant disease stage. And we see the lung cancer average age around 70 years. But again, this is a very large span. We see it in younger patients and in older patients. And we see a shift from the different subsets towards what we call the adenocarcinoma. Those are subsets of lung cancer that have glandular formations under the microscope. So it's a purely descriptive microscopic diagnosis. But from there, it really breaks down into many subsets. We see many different mutations, and they're very different. So I oftentimes get asked, well, is my lung cancer hereditary? Are my children at risk? All cancers are genetic. But this kind of genetics is not hereditary. It is acquired over time. We oftentimes don't understand what the triggers were that led to these genetic changes, but oftentimes they don't have to be very big genetic changes to cause them. And we see some that are more common, like KRAS and EGFR, and then we see some that are not quite as common, like BRAF, MET exon 14, or the ROS1 subtype that we're talking about today. But if you think about it, if you have 2 or 3% of patients affected with the ROS1 subset, this is still thousands and thousands of patients a year affected. So while this is not common in the big context of lung cancer, it is still a very large number of patients affected by it. So it's really an important subset to discuss tonight. So I really want to focus on this. And the more we understand it, as I mentioned, the better. Now, there are 2 types of different changes genetically that are driving this. The most common one is gene mutations. Those are genetic changes that affect the gene of interest directly. And then there is a subset called gene fusions. Gene fusions are basically the alignment of 2 separate parts of the genome. So we have chromosomal breaks that lead to the alignment of 2 separate kinds of gene formations, and they overactivate an otherwise relatively silent gene in the lung cancer background. And this is what happens with ROS1. So we see a bad actor in the neighborhood of ROS1 leading to an activation and overactivation that then leads to transformation. So it's a very unique subset, and it does require a deeper look. They're not quite as easy to test for. So we really need to make sure that these platforms that we're using are up to date and really meet all contemporary requirements, looking at multiple layers of genetic information for us to get the best possible information. And for us in non-small cell lung cancer, when we are treating this on an expert level, this is really the first and inevitable necessary step to really finalize the diagnosis and then be able to offer the best diagnosis for patients' treatment. And obviously, these targeted therapies that match the genetic setup really with the best promise for best outcomes for patients. And the earlier we introduce them, the better. There's a lot of genetic rationale why that is, but best therapies first is a principle that has always applied. We do have a second column of therapies called immunotherapies, therapies where we activate the immune system to fight off cancer, maybe a little bit different, but those typically come after we ruled out one of these actionable mutations in the first line setting. So this is very, very important. Now, there are 2 ways of testing for this. One is on the tissue biopsy itself. As I mentioned, this is not a bloodline or germline related cancer. We really have to go for the tissue of the tumor and analyze it. And here there are 2 layers, the DNA, which is the genetic blueprint, and the RNA, which is the a subset of genetic material that really indicates activity of material. And then in my practice, and I think this is standard of care now, also on a liquid biopsy. Liquid biopsy is trying to extract DNA information from the bloodstream that spills from the tumor into the bloodstream, where we can collect it and use it for analysis as well. They have different rationales why we're using them, but they complement each other in great ways. So it's not one or the other. We really want to use them together in the best possible ways, and then some additional protein testing in a second setting that might be helpful. The reason why this is so important, and as a geneticist, I get very excited about it, but the reason is it's just so crucial to get this information together, that the most comprehensive testing platforms on DNA and RNA basis at front needs to be analyzed. We just have a blind eye to a certain amount of genetic alterations that are best captured when we have these two platforms side by side. The liquid biopsy helpful when in cases we don't have enough tissue, and also to accelerate it because we can really process the samples much quicker, so we get the information relatively quickly. And I think most of the big commercial labs and some of the big academic centers have also corresponding in-house panels, are able to offer these platforms. You wouldn't necessarily see this on the front end, but on the back end, they're really doing what they need to do. There are many commercial laboratories that are doing this, and I would always double check that your oncologist is looking at one of these panels when they're making a statement. And the reason is quite simple. Genetic testing and genetic profiling saves lives and improves survival, and not by a little, but oftentimes by many, many years. And that is simply an opportunity we cannot afford to miss. If we don't understand what we're doing, we're basically resorting to a chemotherapy-based treatment approach. And as you know, in lung cancer, the chemotherapy-based approaches have never been particularly successful. Chemotherapy is a very resistant disease to chemotherapy, so in very challenging settings. It's important to get treatment started with the right therapy. We do change therapy. If you think about it, a cancer, like any biological organism, is a living, breathing organism that can evolve. So what we see in the very beginning may get stronger and more resistant to treatment as we expose it to suboptimal therapies, just like we see with an antibiotic that may not be right. Now, I mentioned the fusion nature of the treatment. The ROS1 gene, relatively indolent in the lung cancer background, but in the fusion setting, reaching an overactive state where we basically have a new gene activation setting. And those can be different partners. There are many neighbors in this fusion construct that can be leading to an overexpression and activation. So we really want to make sure that we capture these new neighboring events, so-called fusions, and ensure that we detect this on our panel. Those are receptors that are based at the very outer layer, called the membrane of the cell, from where they activate many downstream targets that are all potentially involved in the growth of tumors, into the treatment resistance, and also in the spread and invasiveness. I mentioned the NGS, next generation sequencing. That's the test of choice. It can take a little bit longer, but the information is most valuable. This is the most tissue efficient way. And because of the number of biomarkers now in lung cancer, really also the most cost efficient one. So NGS, if not done, if a friend or a person you know has been affected by lung cancer, NGS has to be a request to make sure that this is available by the time that treatment should be available. Again, I mentioned this, 2% of patients have ROS1 positive lung cancer, thousands of patients. What is different about it? Different patients, younger patients. The median here is not 70, but more like 50 years. Patients oftentimes with no exposure to smoking in their history. So a different biology, oftentimes younger patients, most commonly adenocarcinomas. And by virtue of the patient in which this kind of subset of cancer occurs, oftentimes, unfortunately, in advanced or metastatic stage. Enough to make things even more challenging. Many times, about 1 in 3 of these presentations are with metastases in the brain. So if we think about an effective therapy, it has to work in the body, but it also has to work effectively beyond the blood-brain barrier. And by having these therapies inactivating the core switch of cancer transformation, we really can induce a very substantial therapy. Now, the guidelines are very clear. Targeted therapy, best therapy first, and it's very clear that those two terms here are interchangeable. The best therapy for ROS1 is the target therapy. Dr. Rotow will talk about this. If we start therapy and detect a ROS1 fusion later, we really want to course correct as fast as possible, interrupt the current therapy and move back to the targeted therapy to get back to the most optimal therapy upfront for treatment. And we really want to provide the best possible coverage to avoid the occurrence of resistance mutations in the gene, similar like we see resistance with antibiotics in the treatment of severity. And then obviously want this to be as specific as possible. We always get the challenge that we want to treat a cancer as specifically as possible and not treat the surrounding tissues. And obviously they're unfortunately very closely related. So with that said, a broad genetic overview, a very interesting subset, unfortunately with a lot of options. And with that, I'm going to hand it off to Dr. Rotow to walk us through the therapeutic options.
All right. Hi, thanks. And great to be here today and great to be chatting with everyone about this, I think, important subject of ROS1 positive lung cancer. So I'm Julia Rotow. I'm a thoracic medical oncologist at the Dana-Farber Cancer Institute, where my interests include the treatment of oncogene-driven non-small cell lung cancer, including the kinds of lung cancer that often strike people with limited history of tobacco use, like ROS1 positive lung cancer. So with no further ado, I'll dive into talking about where we stand in terms of targeting ROS1 with treatments today in the modern landscape. And I will say ROS1 has been one of those areas where there's been a lot of progress very quickly. We've gone from having no drugs to target ROS1 to having multiple drugs and increasingly improving durations of benefit from these agents over the last year. So, I think there's nothing good about a diagnosis of lung cancer, but we'll say finding a ROS1 as a target is a good biomarker. And I usually tell patients this is going to give us a lot of useful treatment options with, hopefully some good, meaningful duration of benefit before patients need to move on to things other than targeted therapies. So with there, I'll start with just talking a bit about the current treatment landscape. And as you heard, I think the key feature here is really testing for ROS1. If you can't do any of these things unless you actually find the biomarker. So I do agree that the one key message to take away from this entire evening, from my perspective, is to be sure as best as you can that you and your doctor have talked about, have you had comprehensive biomarker profiling? Have you really had complete testing? And is it complete by modern standards? So not just DNA-based testing, but if DNA-based testing was negative, was RNA-based testing done, especially in younger patients or in patients without history of tobacco use, because the ability of our test to detect alterations has changed over time. And the degree to which we can be comprehensive, of course, has changed over time as well. So it's never a bad conversation to open up in conversation with your oncologist to see what they think about the current status of your biomarker profiling. With that, though, we'll go from the point of having found a ROS1 fusion. And that's usually something that we're finding, as you heard, at initial diagnosis, part of that initial biomarker profiling that's being done. So we often know it before someone starts their initial dose of treatment, their initial dose of chemotherapy. Occasionally, we do find it after someone started chemotherapy, and then I agree our usual practice, and that's consistent with guidelines, is to switch from the chemo onto a ROS1-directed drug. You've actually known about ROS1 gene fusion since about 2007, so almost 20 years, 18 years now. They've been actionable in clinical practice for just shy of 10 years, so it was almost 10 years ago that our original ROS1-targeted agent was approved. These are called ROS1 TKIs, or tyrosine kinase inhibitors. But basically, all these ROS1 fusions cause excess ROS1 signaling in the tumor cells. And these ROS1 inhibitors bind to ROS1 and help to shut it down to bring that signaling back into balance. And the tumor cells are very dependent on that signaling to survive and to grow. So when they get hit by a ROS1 inhibitor, they tend to die. So that's how our current generations of ROS1 targeted therapies work. Now we have actually 4 different approved ROS1 inhibitors right now and more in clinical trials. We're showing data within clinical trials so far. So you actually have a lot of drugs that have been used over the years to treat this. And when I think about targeted drugs for lung cancer, there's a couple key features that I'm thinking about when I'm comparing drugs or giving patients advice about what we should use in treatment. First, we're thinking about how good is it against the cancer? How good is it against the fusion? And that's things like measuring the response rate, so how many tumors shrink well on it, and things like we call it progression-free survival, but how long does it tend to work against cancers before the cancer grows, and maybe we need to change treatment. We want the response rate to be as high as possible and that progression-free survival to be as long as possible. We're also thinking about things like what's the safety profile or the side effect profile? What's the balance of side effects to anti-tumor efficacy? And for ROS1, as with many of our targeted therapies, we're also thinking about features like how well does it cross the blood-brain barrier? A lot of people with lung cancer will present with some brain metastases. It's often a thing where we're looking for a diagnosis with brain MRIs. And if we find them, we want to make sure that they're part of the treatment plan, how we're going to manage them. And if possible, we want to prevent brain metastases from happening as well, or keep them under as good a control as possible. So we'll often talk about with different drugs when we're looking at them, how well do they cross the blood-brain barrier? What's the data for how well the drug does against brain metastases? Are they shrinking them at high rates? Are they holding them under control at high rates? So that's a really important feature when we think about managing the disease in practice. And then lastly, though tied in very closely with anti-tumor effect, each of these different drugs has different potencies, like how strongly it binds to ROS1, and it has different resistance profiles. So we know, unfortunately, tumors do eventually get resistant to these targeted therapies. And there's many different ways tumors can do that. But one way is by picking up new mutations in ROS1 itself, in addition to the original alteration, which block drug binding. Like it creates an abnormal shaped protein that the drugs can no longer bind to. Each drug is different in their ability to cover these sort of acquired mutations. So we think about all these things when we're comparing different drugs. So I thought I'd take us on a little story back through what we've been using and what I think we're currently using for ROS1 and where we're going in the future. So historically, about 10 years ago, we actually had our original ROS1 drugs. They were approved a couple years apart. They were called crizotinib and entrectinib, and they both varied in that crizotinib was like the original drug where it covered ROS1, but a lot of other stuff too. So it's also being used for MET and for ALK and for other targets like ROS1 and lung cancers. But it didn't cross the blood-brain barrier very well, and that I think caused some limitations in how well it could work long-term for patients. More recently, we've seen the advances of ROS1 drugs that could cross the blood-brain barrier. So that was a drug called entrectinib that came out a few years later, again, just kind of giving you the landscape of what we've been using over the years and why we feel like there's been progress in this area. So entrectinib was able to cross the blood-brain barrier, and in that sense, we think probably offered a little better CNS control or brain metastasis control of the cancer. But they were still both marked, I think, by kind of on average, they're working about 1.5 years. And they weren't, I would say, precise for ROS1. So when we think about drugs, we know that we want it to hit the target we want, ROS1, but anything it hits outside the target can contribute to side effects, right? If it's hitting other proteins that have their own functions in the cells, the more you're hitting those, the more you might see what we call off-target side effects. So crizotinib hits ROS1 really well, but it also hits something else called MET. And MET is a different protein that cells need. When you inhibit that, you get side effects related to that, like fluid retention and stuff. And same thing with entrectinib. It hits ROS1 really well. It hits a different protein called TRK, which looks a lot like ROS1 to the drug. And when it binds to this, you get side effects related to this thing called TRK, which has a lot to do with probably brain function or brain development. So people who are getting TRK inhibitors sometimes can get trouble with dizziness or imbalance or kind of mood or kind of neurocognitive changes. So it's something you watch for on these kinds of drugs when they're hitting TRK. And all these proteins, when you look at their actual sequence, they look very similar. So it's hard to create drugs that hit one and don't hit the other. So why we see this sort of overlap. So this is where we stood for actually multiple years, almost since crizotinib, almost 7-8 years actually, until we started seeing our more recent generations of ROS1 drugs become available. So we've had a couple of recent new drugs approved. It's a drug called repotrectinib we had used for a few years, and more recently a drug called taletrectinib. And that kind of takes us up to current status of what's out there or around when you're talking about treating ROS1 lung cancer. And I'm going to focus a bit on taletrectinib because it's our most recent drug approval, and I personally think has the best data. So it's what I'm reaching for in the frontline setting if I'm not treating people with a clinical trial. And then I'll talk a little bit about repotrectinib as well. But when we are treating patients with these drugs, we want to know things like how long do we expect them to work on average, and what are their response against the cancer. So what do we see for these agents? So I think it was a big change for all of us when we saw repotrectinib become available, a more recent one, because we saw the average duration of benefit, I'll call it, it's the progression-free survival, I'll call it duration of benefit for easier, that's not quite the same number, was just shy of 3 years. And that was a lot longer than about 1.5 years that we were seeing on the older drugs. I think caused a lot of excitement and sort of changed our practice. We shifted that way. But it's repotrectinib also targets both ROS1 and TRK. So we had some trouble with similar sorts of side effects with that TRK toxicity. So you saw some neurocognitive side effects and dizziness and imbalance. More recently, we have the drug taletrectinib that's become available. That's the one that a lot of us are reaching for right now, which we think avoids TRK a little bit more. So we get a little less of the dizziness, a little less of the neurocognitive side effects, and probably a little longer efficacy against the cancer as well, running more towards about 3.5 years on average on drug. So a lot of us have reached towards this, just trying to reduce some of the side effects, improve duration of benefit against the cancer. None of these have been compared head to head. So I think it's still, if we don't know what would happen if we did a clinical trial comparing all of these different drugs, but absent that, for these sort of more rare oncogenes in lung cancer, we're often reaching for these sort of looking across trials and comparing how people did historically in one drug versus another, because we have to make a decision somehow. Now, like our most recent drugs, both repotrectinib and taletrectinib, they do cross the blood-brain barrier, and that's quite important when we're thinking about how our patients might do on drug. So this is something that we watch really closely in our clinical trials. So if you look at responses in the brain across these different studies, you can see response rates again, over 50%, probably closer to 2/3 to 3/4 of patients having meaningful reductions in brain metastases. And it's something I'll watch closely and often thinking about when we're treating patients and trying to decide, do we need to start with a targeted therapy? Do we need to do other things to manage the brain disease, like radiation-based treatments, for example? But for ROS1, because all of these drugs do tend to cross the blood-brain barrier quite well, in most of our practices, we are indeed trying to rely upon these targeted therapies before going to radiation, trying to put off some of the side effects that people might experience from these other types of modalities of therapy, like radiation. So stepping forward a little bit, when we think about treating targeted therapies, we're often trying to give not just one targeted treatment, but multiple in sequence, right? So a tumor might get resistant to one, but maybe won't be resistant to another. So you'll often see us doing things at acquired resistance to a ROS1 targeted therapy, doing repeat genomic profiling, trying to look for something to explain why the tumor got resistant. Is there another gene mutation? Is there a different gene that's overactive, that's taken over the function of ROS1? We call it a bypass pathway. So we'll often do things like, just like the biopsy and profiling you heard about before, we'll often do it at acquired resistance to try to see what's happening now in the tumor. Can we target that with something more precise? Whether that's a combination of targeted drugs or seeking a clinical trial that might target something new that we find, or simply trying to understand what's our confidence in sequencing these drugs next. And for each of the agents I just mentioned, I know it sounds like an alphabet soup. For each of the agents I just mentioned, there is some data as well. If you treat people not just who've never had a ROS1 inhibitor, so that first kind of treatment, but for people who've maybe had ROS1 drugs before and are now sequencing them, there's often data from the clinical trials telling us, well, what fraction of people tended to respond, depending on what kinds of treatments they had before. So we're often kind of looking at that when we're trying to give people advice. Okay, what should we do next if the tumor stops responding to current therapy? I have a few minutes here left. It's a lot to cover in 15 minutes. So I know that's a whirlwind through what we're thinking, just trying to give you some idea of when you have this conversation with your oncologist, what's your oncologist thinking about when trying to give you some good advice about what to use to treat your individual disease, and just why knowing those biomarker profiles matters so much. Because if you didn't know about it, we're going to talk about things like doing chemotherapy or other more standard treatments, or chemotherapy plus immunotherapy, which we tend to use in lung cancers without some of these mutations, without ROS1 fusions, for example. So kind of just hopefully setting the stage a little bit there for what we're doing. I will highlight that something we always like to talk about, especially in academic centers seeking clinical trials. Certainly all of these drugs were once drugs in clinical trials. So we always say we never know for sure what in a trial is going to be the next thing that we use in practice, but certainly a nice way to access potentially novel drugs, especially if there's very good preclinical science behind them. There's a lot of stuff going on in trials that are interesting. I highlight a drug called zidesamtinib, which has shown some nice activity, including for people who've had resistance to multiple other prior ROS1 targeted drugs. That's what I'm often looking for if I'm trying to seek a clinical trial for a patient in this setting. And it's just a nice example of one among many things that we might consider outside of the standard of care as well, just now if you're seeking these sort of treatment strategies. One last minute I'll cover, I think, an important question we get asked a lot in ROS1, which is, what about immunotherapy? Should I get immunotherapy? Because I think if you read about lung cancer after a diagnosis, a lot of what you read will be about immunotherapy, trying to stimulate the immune system to fight the cancer on your behalf. And there are a lot of subsets of lung cancer for which that has worked really well. And in fact, it's the kind of benchmark, so to speak, the foundation of a lot of our first treatment regimens we use in lung cancer, either immunotherapy alone or immunotherapy combined with chemotherapy. For ROS1, like many of these sorts of mutation-positive lung cancers, unfortunately, immunotherapy has not worked very well. It doesn't tend to be, the tumors tend to be called immunologically cold, not super responsive to immunotherapy. So that's another reason why we don't usually like to reach for that, because we think it probably won't be as effective. Instead, we really want to focus on getting people access to drugs that we think are very likely to be effective, like targeted therapies that target ROS1. So I tell people we'll probably be on either an immunotherapy track or a ROS1 here, directed therapy track. Just need to know what track we're on so we give you the right treatment at the right time. So with that, I'm happy to field questions a little later on, but I'll turn over, I think, to our next speaker at this point.
Yeah, I think I'm the next one. So as Dr. Rotow said, we are going to answer questions at the end. Some of you are already typing questions in the chat. Please keep doing so, but we'll answer it at the end. Basically, if you notice in this webinar, we're not using slides, okay? So we feel uncomfortable not using slides because as a doctor, we like to show you a lot of curves, statistics, and things like that, but a lot of patients and caregivers always told me that they get confused with so much stuff. You know, I thought actually it's easier to show slides because I can show you some pictures. But anyway, so that's why be patient with us, because for us it's hard not to talk without slides. Anyway, they asked me to talk about, I'm Luis Raez again. I introduced myself at the beginning. I am a thoracic oncologist here in Miami. I am a director of a cancer center called Memorial Cancer Institute. That is these are the public healthcare system hospitals in South Florida. We have 6 hospitals here. They told me, asked me talking about what is they are the symptoms, or what they are the adverse events also of the drugs and how we can manage, no? So let's start talking about the symptoms, okay? Lung cancer is very frustrating for every patient and every family. I'm doing that for 25 years, and they always will get the same question, no? So how come I have a lung cancer if I feel fine? Unfortunately, it's true. Lung cancer is not very symptomatic. If you can realize, the lungs are very large organs, so something can be growing inside, and they do not necessarily affect the breathing right away. They don't cause so much pain. It's not like when you have something in your skin growing up, or in the case of breast cancer, it's probably more noticeable because you feel something in the surface of the breast. So that is why lung cancer in general is diagnosed late. If we wait for symptoms, that's the reality of the last 25 years. We wait for symptoms, so close to half of the cancers that we diagnose are late in the way that they are already metastatic. We cannot take them out, so the chances of survival are not very good. So that's why I think Dr. Dietrich was mentioning, it's very important now that if you smoke, you're more than 50-year-old, you come to your screening, okay? You feel fine, but we want you to come once a year, do your lung screening if you qualify with these easy things to remember, so we can catch the lung cancer before symptoms, before you feel anything. So when you have symptoms, as I said, can be late. For example, in lung cancer, you have cough, and cough is a very common symptom, but you can have cough for many other things. A lot of people have cough and they don't worry about lung cancer because it can be the flu, it can be a respiratory infection, even asthma or gastritis, heartburn can cause cough. So anyway, but when you have symptoms, it's because it's a little bit advanced, it's late. And these symptoms you probably know. For example, if we get water in the lungs, we feel short of breath because of the water. We get a pneumonia. Commonly, a lot of times we are called in the hospital. People are arriving in the ER with what looks like a pneumonia, but it's not a pneumonia. It's a lung cancer with a pneumonia on top of that. No, but that's the way that we diagnose the lung cancers. Sometimes we diagnose them with blood clots too. So that's why don't trust the symptoms. Please focus on screening. It's more important that if you qualify for screening, it's paid by insurance in the United States, you come to do. You won't believe it, but we need to screen 16 million Americans. 16 million Americans. So that's why we need a lot of help. A lot of people needs to be screening. Yeah, a lot of people is more than 50-year-old and he has been smoking more than 1 pack a day for 20 years. So that's why, please, we need to do the screen. Now, talking about the second part, adverse events from the therapy. Now, Dr. Rotow has described all of these agents that we use for ROS1. And in general, we will tell you that target therapy gives much lower amount of adverse events than chemotherapy. Yeah, we prefer, as Dr. Dietrich said, we like to use target therapy first for ROS1, not only because it's more efficacious, it's also because the adverse events have a much lower rate compared with the palliative chemotherapy that is not very efficacious. Okay, so that's why. Second, most of the adverse events are tolerable. That's why we like to empower the patients to learn how to deal with them, because as Dr. Rotow mentioned also, the ROS1 patients can live years, but you can live years if you take the therapy. If you think that the therapy is not good for you and you don't trust therapy, and I have seen that before, you may not be happy taking the pill. You may be overwhelmed for a side effect, that may not even be life-threatening. And if we put you back on chemo, your survival will be short. That's why it's very important that the collaboration of the family and the patients when we talk about adverse events, because each of us have a different definition of what is quality of life. And we, of course, respect your definition of quality of life. But it's important to understand that the benefit of these agents can be for years. All of us have. I have a patient with ROS1 taking 4 of these agents for 14 years. So that's why when we can make ROS1 is an area, we can make this a chronic disease, but we need to take all these agents. So, okay, so to be more concrete, for example, the most bothersome probably are dizziness, no? The ones that we use, especially the ones that we use at the beginning, entrectinib, repotrectinib, they cause ataxia and they cause dizziness. And this is a very little bothersome because, well, luckily for us, it's not very common, but there is a small amount of patients, maybe 15%, that has persistent dizziness. Now I have a patient taking Repo, for example, for a couple of years, and he told me he was always dizzy, unfortunately. And the management for dizziness is very frustrating because there is not too many things that we can do. Of course, we take precautions. I told my patient, don't drive, for example. We don't want him to get dizzy on the road. We consult neurologists, we consult ENT specialists, maybe trying to find the dizziness was in something related with the ears or the balance. But really dizziness is something that bothers the patient and the ataxia too. The other common side effect is fatigue. A lot of people think that the most common symptom in lung cancer is cough, but it's not cough, it's fatigue. And on top of that, all of these agents cause fatigue. Or it's hard to know if these agents cause fatigue because everybody is already fatigued. So it's hard to know who to blame for the fatigue. Something specific of these agents is also gastrointestinal symptoms like nausea, vomiting, diarrhea, constipation. But this is something that we can deal. If you're constipated, we give you medication for constipation. We give you fiber so we can prevent severe constipation. If you have diarrhea, we'll give you Imodium, we'll give you a diet that is low in fatty meals. So we manage that. Usually it doesn't ruin the quality of life. Something interesting is sometimes these agents cause vision changes, like flashlights, that usually we only see with the first agent, crizotinib, the first one approved years ago, and the last ones like taletrectinib that Dr. Rotow mentioned don't cause that. And also from this first group of side effects, taletrectinib, the last one approved, doesn't seem to have dizziness, doesn't seem to have ataxia. So that's why it's great for the patients that I guess as new agents are coming for this ROS1, the side effect profile is changing. No more visual problems, no more ataxia, no more dizziness. Now we have more maybe GI symptoms, but I rather deal with GI symptoms because they are not as, they don't ruin your quality of life compared with dizziness and other symptoms that are harder, no? Some of these agents also cause edema, but it's not life-threatening. You know, this is edema because of retention of fluid retention, especially in the legs, sometimes in the hands. But this is not a life-threatening. Certainly, patients get worried, but you need to give assurance that this is not cause permanent harm. Something also bothers the patient is the peripheral neuropathy. But a lot of times, you know, the patients, especially in the tip of the fingers, the peripheral neuropathy is already present because a lot of people started on chemo. So then maybe you have to realize the peripheral neuropathy was already there because of the chemo. Also, unfortunately, we have so many people with diabetes in the world that they already have a peripheral neuropathy, so it's easier for them to get more peripheral neuropathy. Something interesting is that they have dysgeusia, or change in taste, but that is another one that may bother you, but it's not any life-threatening adverse event. With some of these agents, patients used to put weight. Actually, in lung cancer, you know, a lot of our patients are underweight, and to put in some weight is not bad. The problem is when it's a good problem because these patients can be on these agents for a long time. It's not the same to put weight for 6 months than to keep putting weight 3 or 4 years after. No, that becomes a little bit bothersome. And as you notice, when we talk about adverse events, we always draw blood on the patients. You know, I wrote the guidelines for ASCO and in CODA with a group of doctors, and we really like you to be drawing your blood at the beginning, maybe a little bit more often, 2 to 4 weeks, maybe when you are stable, no, every 6 weeks or 8 weeks, because there can be some changes in your blood, no? The one, maybe the most common is increase of your liver enzymes, no? So the liver enzymes increase in numbers. I guess sometimes people say, but what does that mean? How do you explain that? Well, I guess I tell you the liver is like inflamed, you know, the liver is inflamed. And certainly, most of these agents can cause increase of the liver enzymes. That's why it's important to monitor them. It's important every time that we do blood, we check the liver enzymes, no? Another thing that is also luckily not very common is pneumonitis, no? A lot of this pneumonitis is like inflammation of the lung, not because of the cancer, but to the medicine. Unfortunately, our lung cancer patients have to suffer lung damage from the cancer, and now they have to deal with lung damage from the medicine. That is not very common with immunotherapy, but it happens. I think it's less common with this oral target agent. So it's less common than what we see with immunotherapy. Radiation, for example, causes a lot of lung inflammation. We call them pneumonitis. But it seems that we have to be watching, you know, we have to be observing the patient. We have to do surveillance because these are things that are important. You know, in cancer, a lot of agents decrease the white cell, the defenses. So the patients always ask me, you know, how are my white cells? I am neutropenic. I am in risk of bleeding with low platelets, thrombocytopenia. So these are more common with chemo. You know, we still check your blood for all of these things, but with these target therapies, the chances to get leukopenia, thrombocytopenia, low platelets, no, are not very common, but we still always check that. And remember also, we are taking these agents for a long time. You know, we are very lucky that with these agents, you can stay 3, 4, 5 years. And for that reason, we need to monitor you. You know, if you don't have a increase of your liver enzymes the first 2 months, doesn't mean that the next 4 years you will be fine. You know, we always have to monitor, because I'm also remember it's not only this medication, it's the interactions. You know, if you're taking cholesterol medication, that can also increase your liver enzymes, and we need to know about that because we don't want to blame the cancer medication for what the cholesterol medication is doing, and we don't want to stop your cancer medication when we can easily stop your cholesterol medication for a while and see the liver enzymes going down. No, I'm giving you some examples. No, yeah, but that's very important. Anyway, I think I'm going to stop here because we have one more speaker. So we have, I'm going to introduce now Andrew Supek from the GoTo Foundation. That is one of the sponsors of the event, and then we will take questions at the end. Thanks for your attention.
Thank you so much, Dr. Raez, and thanks for the opportunity to talk today. What I wanted to do was share with everyone here a little bit about GoTo for lung cancer, and then also keeping in the theme of the day of sharing information about ROS1 positive non-small cell lung cancer. I wanted to share a little bit about the recent trends I'm seeing in ROS1 research and why I think it's an exciting time for the research progress in ROS1. So to start off, GoTo is a national lung cancer advocacy organization, and we're dedicated to increasing survival and quality of life for those at risk, diagnosed, and living with lung cancer. We do a number of things to directly help people who've been affected by lung cancer and living with it. We offer several programs and resources that are directly designed to help both the people with lung cancer and their loved ones and supporters find what they need, no matter where they are on their journey from diagnosis up until long-term survivorship. And just to give an overview of some of the things that we do offer, we offer multiple formats of educational resources to access lung cancer information in the way that works best for you. We have both online, which is located at our website, goto.org, and also print educational material pieces. And these are all aimed at covering a number of topics, including treatment, managing quality of life, navigating lung cancer care, and everything in between. They're also available in multiple formats because we know different people want different information at different times and in different ways. And so we have everything available from a comprehensive patient handbook that covers all aspects to one-page resources that are kind of bite-sized information on individual topics, everything from side effects to certain treatments, and how to navigate your care. In addition to kind of traditional educational support materials, we also offer a number of ways to hear information about lung cancer and how treatment is evolving. One of the prime examples is our Living Room series. And our Living Room series is we invite a number of lung cancer researchers, clinicians, people who are helping support lung cancer patients to meet in person in our California office, but also streamed globally across the country to share about recent advances in lung cancer, topics of care, and importantly, to allow people in the audience to ask questions. We have people in the room can ask questions, but also we have online chat. Those viewing online can submit questions and ask. And so just a number of ways, to support in different formats. We also offer a number of personalized support initiatives to help you navigate the lung cancer journey. We have first the things that people ask are for help finding locations for care and support. We maintain lists of both our centers of excellence, which are lists of treatment centers across the country that have multidisciplinary lung cancer teams and specialize in treating lung cancer. And also things like we maintain a database of support groups that are local for connecting you with your local resources when you need to find. We also have a 1-800 helpline. We have people trained, social workers and care navigators who've worked in lung cancer for a long time to answer any question you have about, what to expect from your diagnosis, how to find resources, how to navigate the impacts on your quality of life, or, organizing and paying for care. Just anything you may have, we'd like to make available as a resource. And we know that a lot of times, while it can be helpful to talk to, patient advocacy organization representatives, some of the best advice comes from people who understand what you're really going through. And to help with that, we offer our Phone Buddy program. And that's a service where we can learn more about what you're experiencing, what your diagnosis is, what your treatment is. And then we have a number of volunteers that we can try to match you with who have a very similar experience to what they're going through. And then we kind of get out of the way and let you two share and talk to each other, learn from each other's experience and sharing that information only, another fellow patient can really understand. And then last thing that I want to share about with individual support is our Lung Match program. And so Lung Match is a personalized clinical trial and treatment navigation program. So there's a number of navigators. I'm one of them myself, and there's others. We all have backgrounds in research or clinical care. I was a laboratory-based cancer researcher for a number of years, working at the bench, and we try to keep up on the current advances in lung cancer research and treatments and help you come up with the best questions to make the best use of your time and conversations with your treatment team when you go in. We help do clinical trial searches. We help, narrow down and ask, come up with the questions that you might want to ask at your next appointment. And we're there as a resource to go through. There's things that are changing all the time, which is really great news. But it can be a lot of overwhelming to keep up on all the new advances. And so that's really what Lung Match is helping you to help with. And then lastly, we also help connect the lung cancer community with each other for support and for advocacy opportunities. We have an online community which is based in a forum format for those that like to communicate online through a platform called Health Unlocked. We have a really active community on there that just shares their stories with each other, information, asks questions about the day-to-day of having a lung cancer diagnosis. And that's a really great way to share, for those who like to type online. For those that like to connect in person, we try to offer what we call our virtual Gathering Hope sessions. And these are just a way for caregivers, people with lung cancer, advocates to connect over video conferencing like Zoom periodically and just share with each other. What are the topics you're interested in, learn from each other, connect, and really meet that wider community. And then lastly, for those that are looking to get more involved in advocacy work, especially, advocating for lung cancer issues to elected officials, we host our virtual Voices Summit every year where we take patients, family members, and others affected by lung cancer to Washington, D.C. to speak with their representatives and share information about what the community really needs. And we also offer a number of resources to keep you informed on advocacy opportunities throughout the year so you can continue to advocate in your own local community. But, like I said, I'm primarily a member of the research team at GoTo, and I also serve as one of our Lung Match navigators. So beyond just talking the whole time about GoTo and what we do, I wanted to make sure that I ended in kind of the second half of my talk here by touching on the topic of emerging research and clinical trials for ROS1 positive non-small cell lung cancer. And I think we've heard from the other presenters today, great information about the current options and the bit about the future of ROS1 positive non-small cell lung cancer treatment. And I just think, one of the messages that I want to leave to the audience with today is that I think there's a lot of reason to be hopeful as we continue to increase our understanding through research. And there's a lot of advances that are happening. Really having discussions with your treatment team about emerging ROS1 focused research and how that might be important to your own decisions. And, if there are clinical trials that might make sense for your situation is such an important thing in this constantly evolving landscape where we have new clinical trials opening, closing all the time, and we're increasing our understanding. So what I'm going to end with today is just summarizing some of the trends I'm currently seeing in ROS1 clinical trials, and just to give you kind of an overview of what's happening and all the exciting stuff that is happening. I think I looked at this at the end of last week. Clinical trials are changing all the time, which is a great thing. But this is no way a comprehensive list. I'm just trying to give a snapshot of what things are out there and give you a view of just how exciting the research is that's going on. So all the example trials I'm mentioning today, as of the end of last week, they were mentioning that they had open locations, but that, like I said, that can change, and the best people to ask for information about current clinical trials is with your treatment team. So to start off with some of the trends I'm seeing, as our other speakers mentioned, unfortunately, ROS1 positive lung cancer can become resistant to initial targeted therapy treatment. When we're doing that, there are a lot of clinical trials that are looking into, what can be the next step for treatment, developing new treatments that work in this resistant setting. So one of the first things that I'm seeing right now in research is the development of what they're calling the next generation ROS1 inhibitors. These are also targeted therapies, or you may have heard them referred to as TKIs. They're the drugs that were mentioned so far, but these next generation ROS1 targeted therapies are being developed to specifically attack the current changes that can occur in ROS1, which they call resistance mutations, that may lead to our current ROS1 therapies stopping working and having progression. And we're hoping that at the same time as these new next generation target therapies are being developed, not only will they be able to target the changes in ROS1 that may be causing resistance to other therapies, they may actually be more selective to ROS1 and avoid contributing to side effects like the other speakers were mentioning. A prime example right now is zidesamtinib, which is being evaluated in the ongoing ROS1 trial for ROS1 non-small cell lung cancer that's been treated previously. And there are actually locations for this clinical trial across the US, but it's not the only one. There's other next generation ROS1 inhibitors. They're very early stages of research that may, if they do show positive results, we'll see clinical trials for those. So I'm definitely seeing a trend in that. The other thing I'm seeing are the use of novel drug types and actually combination treatments that can be given with some of the existing treatments we're seeing, like our currently available ROS1 targeted therapies, and these are being explored as well. And one of the reasons that these combination therapies and different drug types are being explored is that, certainly one way that resistance to our ROS1 target therapies can happen is because of a change in ROS1 itself. But sometimes resistance to initial treatment can happen because of changes in cancer cells and things that are not ROS1. So using a drug that targets non-ROS1 changes may actually be helpful in some cases of resistance. And so there are clinical trials looking at this. For example, there's a current clinical trial looking at giving some of the existing ROS1 targeted therapies we have with a new drug called amivantamab, which targets something called MET. And the reason they would do something like that is in some cases, changes in MET may cause resistance to initial treatment in some cases. And so combining the two targeted therapies together can be an effective treatment. So currently that trial is at 3 large cancer centers in the United States when I last checked, but there are other combination therapies and different targeted therapy trials that we'll continue to see. And the last trend I wanted to call attention to is that while ROS1 and actually a lot of targeted therapies for other mutated forms of non-small cell lung cancer have been to this point widely used in stage 4 or metastatic treatment, so lung cancer that's spread from where it started to other parts of the body, researchers are seeing if these targeted therapies can be used actually as treatments for earlier stage disease or being given as what they call adjuvant or neoadjuvant treatment before or after surgery. And this is no different from ROS1. I actually looked, and there's a current example of a trial called the TRUST-4 trial that's looking at giving the ROS1 targeted therapy taletrectinib for people who are diagnosed at stage 1B to 3A lung cancer after that cancer is removed by surgery. And the idea is that they want to see if giving the ROS1 targeted therapy taletrectinib actually lowers the chance of the cancer coming back after surgery. And so we're seeing that trend across lots of targeted therapies, including for ROS1. And there are 3 locations for that trial last time I checked. And so I think it's exciting to me, and hopefully I've conveyed some of that to you to see all this work. And also I recognize it's a lot of information to sort through. And this is constantly changing as trials close and new ones open. So, if you have questions about how to prepare to best talk to your treatment team about clinical trials or what questions you should be asking about clinical trials, please feel free to connect with, certainly I'd be happy to help you through the Lung Match program, and you can just access the calling our 1-800 helpline or looking at go2.org. But there's also a number of other advocacy organizations and people focused on helping you sort through that information. So I encourage you to, look at what resources are available in the community and help, make some of the great offerings of advocacy organizations, part of your team. And with that, I just wanted to say thank you for the time to present today and turn it back over to the rest of the panel.
No, thank you very much to everybody for the presentations. Now we have probably 20 minutes for question and answer. I want to start with a very basic question. Let me see for Julia, because we need to empower our patients, I think. So you will do in every new lung cancer patient liquid and tissue at the same time. So how is your approach? And
yeah, it's a great question. I will say for most of my patients, I am doing both liquid and tissue-based testing first, both at diagnosis, looking for what the biomarkers are, but then also at acquired resistance, trying to see are there any mutations. Now, the most important is at diagnosis, and they test different things, right? Tissue is very sensitive. You're feeding the tumor cells directly into the assay, but it takes longer, up to 3 weeks or so, and you have to have enough tissue on your biopsy to do it. So it's the gold standard, but slower. Liquid-based testing, it tests something different. It tests for shed DNA, so it's less sensitive. You have to have enough DNA shedding from the tumor, not cells, but DNA, to pick it up, and then they run that through the assay. So you can get a positive result that gives you your answer. It finds the ROS1. We can treat based on that. It's very accurate if it's positive. But if it's negative, I always tell people it's actually just non-diagnostic. It doesn't rule out something being there. It just means there wasn't enough around to detect. And then I'm waiting on tissue-based testing. Now, at acquired resistance, it's really interesting because same things apply, those same considerations, but also it's a little different, right? At acquired resistance, the tumor has been evolving over time. So there may be different patterns of resistance in different areas of the cancer. A biopsy can only test one area. Liquid biopsy, it's DNA shedding from the entire body of the tumor. So you might get a little bit of a sense of the mix of resistance as well.
Yeah, I think I wanted to comment that because there is no perfect work. There is no perfect test. For example, you mentioned that the RNA in tissue is probably better than the DNA. But for example, in our daily life, sometimes 20% of the patients don't have enough tissue, so that's why we need to have a test. And if there's not enough tissue, the answer for the doctor to the patient cannot be, oh, there's not enough tissue, I'm sorry, and now I'm going to put you on chemo. So we need to do the extra mile and say, no, now we need to do blood in everybody. As you mentioned, blood is not very good. It's not very good, but I can give you an example. For example, I have a patient that he was enough tissue, and for some reason the tissue didn't catch the ROS, but the blood did it. It's not very common for the blood to catch a fusion like ROS ALK, but this patient, he was in the blood. If I would not order the blood, we would have missed that very important finding, because in the life of that patient, this is extremely important. So my idea is, if, I don't know, 2% of the Americans have these genetic aberrations and 240,000 have lung cancer every year, we need to be sure that we find these 4,800 individuals every year, and that's not happening. Most of our sponsors can tell you, oh yeah, our pill is being used for 1,500 people, our pill is used for 1,000, my pill is used for 500. There is still a group of patients that we cannot still find. That's why I think most of us do in the academic centers, I'm sure Martin does the same, the blood and the tissue, because we cannot miss any single ROS patient, so I think that's the idea. Anyway, I want to give thanks to Martin that he's answering all the questions in the chat. You're already busy. You answered like 26 questions, but some of them are very important. I want the public to hear about that. That question, for example, somebody was saying for the survivors with ROS1, how do you follow them, Martin? And can you repeat the answer that you did for this specific person? How do you follow a person that is on ROS1 taking TKI?
Well, I do want to say I've given sort of a rough overview how I would do it. I think it really depends on the context. There's sort of a guideline but you really adjust it to the level of response. How long has a patient been on the drug? I think in general terms, I get imaging of the body with CT scans every 3 months, an MRI at baseline, and then it's a little bit more controversial how often you surveil a brain that has no brain metastases. I do it at least once a year, and obviously as directed by symptoms. If I'm more motivated and the patient is not afraid of the tightness of the MRI, maybe do it every 6 months. The brain, obviously, a particular area of concern. And if I need more information, sometimes a PET scan can complement the findings of a CT scan, but a CT scan is quicker, has lower radiation exposure, is, in my opinion, sufficient for the general surveillance. I didn't include any sort of recommendations beyond my practice. For ctDNA, the guidelines don't incorporate it yet for surveillance. We have some emerging data, and it's certainly interesting. I mean, it's looking very promising, but it's too early to say this is the frequency. But it really depends on the context because of the non-invasive nature. If I have a patient where I need to get a quick response assessment, I sometimes get it just a few weeks in, and sometimes I don't get it at all. It really depends on the individual circumstances for patients. But every 3 months I think it's a reasonable time frame to get scans, even though in all honesty, when we get out further and further, we sometimes drag our feet a little bit, and I want to save our patients the time in the imaging center.
Excellent. There was a question that just came about there is a patient that said my oncologist orders 2 types of blood biopsies and MDX. It's probably MRD. Do you use MRD, Julia?
I do not. I think it's an interesting technology, right? And I think it's certainly something that I hope will be a useful tool in the future. Right now we follow folks based on imaging scans and symptoms, but primarily imaging scans guiding our understanding if the tumor is still under control. Is it growing or not? Are there new spots or not? And the question is, if we added plasma-based testing, say detectability of tumor DNA in the blood or not, either clearance of that or increase in that over time or reappearance after clearance, would that give us a better understanding of disease behavior in a way that we could change therapy in a way that would improve patients' long-term outcomes? Those are all open questions. Can we detect this effectively? Does it predict effectively for change in how the tumor will behave? And then if we act upon it, are we actually helping our patients by changing treatment sooner when the scan shows things are still under great control? Those are all open research questions. So because of that, I think it's really an important area to study. But I don't send, say, serial ctDNA or MRD-based testing to my patients during therapy, just because right now I'm not going to change their treatment based on it. So if it looks fine, we're all going to be really happy. If it looks bad, I might put that in quotes. So what if we see an increase in ctDNA fraction in the blood? This can bring stress and bring worry, but we don't actually know if it means there's going to be a change in disease behavior. And I've definitely had some patients come to me who've done this through other centers and other settings where this happened and their scans continue to look fine. We've never had to change therapy. It's been a year later. So I don't send it, though I certainly understand that there are some who have this practice who like to get this tested.
Yeah, this is a very important question because I guess for the audience, so liquid biopsies are many different types of liquid biopsies, no? So that's why the discussion today about ROS1 is for diagnosis, no? We do this called next generation sequencing, NGS, and we identify the ROS1, so this is for diagnosis. But now we have also liquid biopsies that we are researching to track tumor or to diagnose recurrence, no? So you are post-surgery, we are trying to find a technology that can detect the recurrence in your blood before the CAT scan, no? We call them that MRD, minimal residual disease, no? Or we have a patient with stage 4, and we are not very happy because, we are very lucky that we have survivors 5, 6, 7 years, but the only way that we track the tumor is with CAT scans, and then it starts to get worrisome to giving so much radiation, but we don't have anything else. So that's what would be amazing if instead to be doing CAT scans every 3 months or 6 months, maybe we can draw blood and tell you, hey, your tumor is doing well, is disappearing, or your tumor is not doing well and now it's coming back. So we need to change therapy based on the blood. We don't have to worry about the CAT scan, no? So that's why, as Dr. Rotow said, it's a very exciting field. A lot of us are doing research on that, and hopefully sooner than later, we will be able to do the tracking the tumor in the blood, the diagnosis of recurrences in the blood, So we will not have to depend of all of these CAT scans and PET scans and all of this irradiation. So that's why, but as Dr. Rotow said very clear, the fact that they're available doesn't mean that they're a standard of care. Our societies still do not recommend for lung cancer. I know that for colon cancer, they are a little bit more advanced, you know, but for lung cancer, we are doing the studies. So they will come in soon, the studies that will prove that this can be a standard of care or not. Martin, you answered a very important question. You know, there is somebody that they said after surgery, if you are clean and if you are ROS1, you will still have therapy for ROS1 after surgery.
So it's a good question. So we know for some subsets of lung cancer, EGFR and ALK in particular, we have approved therapies after surgery and also after radiation. So it's really a matter of how effective is the therapy and how well is it tolerated. And for ROS1, we don't know the answer. I think some of the concepts from EGFR and ALK seem plausible in the context of ROS1, but the trial in studying this adjuvant post-surgical use of the drug is certainly not anywhere near informative yet. So we're waiting for more information. Outside of a clinical trial, I would probably not offer it. But it becomes more challenging. If I remember the question correctly, there was a ctDNA positivity. There may be other high-risk factors. I believe it was a stage 3 disease that was looked at. So there's certainly enough concern for recurrence that we should look for an introduction of closer surveillance, maybe. But I'm not sure that I would introduce a drug early unless I see radiographic progression. I simply don't have the data to support that it would improve outcomes in my practice. Obviously, there are different circumstances, and I don't know all the details, so want to be respectful of the colleague. But I think that's what I would recommend. I would probably watch it until I see disease progression.
Julia, there was a very important question here. You know, we are very blessed that we have a lot of survivors now for years. And one of them is asking how many years, you know, it's already taking crizotinib for 10 years in minimum side effects. So what advice are we giving? So what time stop therapy or how we can do that? No, that's a very common question in our survivors.
Yeah, and as I mentioned, I think of ROS1, of all the bad news that people have received with a lung cancer diagnosis, finding a ROS1 fusion is actually good news within that because number one, ROS1 lung cancer can sometimes take a relatively indolent course where it can be very sensitive to ROS1-directed therapies for a long time. I have multiple patients more than 5 years out on their initial ROS1 drugs, and I have patients out more than 10 years. So we absolutely do see folks with this kinds of outcomes. And I know that's not an outcome we get for everyone. It's part of the goal of all this research. We want everyone to be getting these kind of long durations of benefits. But the key point is, one, for people who are actively being treated, it might work for a long time, but if we stop the targeted therapies, we expect the tumor to grow again because I think it's being suppressed, not fully killed. So I definitely encourage folks to stay on treatment unless there's a toxicity that really is preventing it. And hopefully your doctors can work with you on dose modification or changing up therapy, et cetera, as needed. The other big question that comes up, and it came in the chat, was, well, I'm on therapy for an older drug for now, because that was around 10 years ago. Should I change treatment? And I agree with the answer that Dr. Dietrich gave, which is, I don't like to fix what's not broken. If something's been working for 10 years and you're tolerating it well, I have multiple patients just like this, and they're still on crizotinib, even though it's now not the drug I would start if I met someone today with a diagnosis. It's clearly stood the test of time and worked really well for them. That'd be different. I wouldn't start anyone on crizotinib today. I would start them on probably taletrectinib or one of our more modern drugs. But it doesn't mean that we don't know that there are some folks who have extraordinary long durations of benefit, even to these older drugs. And again, it speaks to why we want to find these alterations, because we don't want anyone to miss out on 10 plus years potentially on a targeted pill. That really matters. And I'm so sorry, everyone. I have a conflict, so I'm going to hop off and leave you in the excellent hands of our other panelists here tonight. It was such a joy to join you, and wishing you all a lovely evening.
Thank you, Julia. Good night. Good night. No,
Thank you so much.
Thank you.
Yeah, we're really finishing soon. Yeah, I only want to add what Dr. Rotow said is the other good thing is that there is not still red flags with these drugs, because I understand the patients are worried. If you get chemo, a lot of the chemos, there is a maximum dose that we can give you. The famous one is the red chemo for breast cancer, no? That doxorubicin, that there is a maximum dose. After we go to that threshold, you can start to get cardiac damage, for example, no? Things like that. we have been very lucky with all of these drugs because, as Julia said, all of us have patients for 10, 12, 15 years, and we have not discovered yet something like, oh, if you take 10 years, you get cardiac damage, or if you take 10 years, you get kidney damage, or something like that. That's why if the patients want to keep taking, they are having a good quality of life, and they are not having side effects that ruin the quality of life. We prefer them to take taking until we know how many years is necessary to cure it. I have a question because I want to finish soon for Andrew. What the Go-To Foundation, one of the things, they do a lot of amazing things, but one thing very important is the body program, yeah? Because when our patients are depressed, I imagine if I get diagnosed with cancer, I'm depressed, I'm overwhelmed, I don't want to be calling my friends at work, or everybody around me, but I don't know who to talk to, so I guess if I call the foundation, you can find somebody, I don't know how you pair people, but how do you do that? For example, if I'm a new patient, I'm overwhelmed, I don't know who to talk, I don't want to talk to the people at work, how you guys can help them?
Yeah, no, it's a great question. I think our phone buddy program is a really nice fit for that. So what we do to people that call is we have a kind of questionnaire we ask people when they first enter the program. We learn a little bit about how you've been diagnosed, what treatments you may be on, and just a little bit about yourself. And then we have a number of volunteers and people on our team who are, talk with all of our volunteers all the time and kind of know what their personality is and how they're like. They look at that information and we try to find someone who is, similar to your situation. Maybe, we ask what you're really concerned about, and what you want to talk about is you're going to be on a targeted therapy and you want to know what the experience was like. We might have someone who has been on that targeted therapy, and then we can connect the two of you. And so you can talk about, what was like for you when you were on that targeted therapy, and what advice can you offer me for kind of managing the side effects and doing day to day. So, I think that's exactly what it is. It's a great opportunity to, connect with someone. It's a lot of our phone buddies, end up connecting over email and keeping in touch with the people they're connected with. And so it's a great resource, like you said. So oftentimes the right person to talk to is someone who kind of understands inherently what you're going through. And so it's a great resource.
No, thank you, guys. Thank you. And kudos to our friend Bonia Dario that is not here with us, one of the founders, but she was a patient also, and the advocate, and it's hard to believe that there is somebody more passionate than us, because our life in this fight, but she was really more passionate and inspired even doctors like us, to help and do the extra mile. Yeah, in general, I have another question, is that about the brain meds, so Dr. Dietrich Martin, how you know when to use radiation or when to use the pills or when to use both? Because the standard of care is when we use only chemo and you get a brain med, you go for radiation. And we were lucky that instead of the whole brain radiation in the last 20 years, we had a stereotactic, the pinpoint. But now these pills go to the brain. So how do you differentiate who goes for radiation, who doesn't know?
So I have to say the response rates in the brain with these newer therapies are very, very high. So if I have a patient that gets initial imaging and has a few small brain metastases, I typically just start with the pills and image 4 or 6 weeks later. The responses come very quick, and the vast majority of brain metastases respond, and many of them disappear completely. About 2/3 of them completely disappear, and then radiation is not even in the mix. If a patient is on treatment and they're after 2 years of treatment or 3 years of treatment, we see the occurrence of 1 or 2 brain metastases. A form of targeted radiation is certainly a reasonable consideration to continue the underlying therapy. The radiation in bigger terms is reserved to highly symptomatic lesions, patients where we need sort of emergent relief from symptoms. If there are seizures, that's where I would rather reserve radiation. But I think the vast majority of patients do not require radiation up front anymore. And oftentimes we can convert radiation, if still necessary, to a more targeted form of radiations that are much better tolerated and are overall in a much more patient-friendly manner than the old whole brain radiation that we would offer.
Great. I think, and we still may need. It's not like we're not advocating for radiation at all. It's only like we can postpone it, because there is the amount of radiation that we can do in the brain is not unlimited, because with every radiation there is a little bit of damage. That's why we probably can postpone it, and we have an extra tool now to defend our patient in the future with the radiation. So somebody was asking in the chat about if they are responding to a lower dose, what we do if they are doing well. So as Dr. Rotow said, if you are responding, makes sense to continue because you already did the test. You already are responding, even if it's a lower dose or something like that. Or the old drugs, like we discussed, Dr. Rotow just discussed, oh, I'm still responding to the old drugs. Do I need the good ones that we're using now, like taletrectinib? Probably not yet, as long as you are responding. Certainly, if you are doing a lower dose for some reason and there is progression, always the question comes, oh, maybe you should have had a full dose, you will not progress, or the progression will be later, So that's why we always try to stick to the regular dose, and we only try to decrease the dose if there is some adverse events, because we always want to be sure that you have the maximum benefit, Martin, are you aware there is any data in joint issues on entrectinib?
That was a very good question. I'm well familiar with it. I have patients that described it. And I think the main explanation we are seeing is if they didn't have prior immunotherapy, obviously we can see autoimmune arthritis. But I think sometimes the NTRK inhibition can cause peripheral neuropathy, peripheral sensory issues, and body aches, muscle aches, myalgias, or joint aches, arthralgias are actually quite common and well described. And they typically respond pretty well to dose adjustments if they're not bearable. Another opportunity would be to switch to one or more of the newer NTRK-sparing drugs like taletrectinib, where that is not as common of an issue because we don't see the coverage of the NTRK off-target receptor. So, but I've seen it as well described. It's technically harmless, but it's obviously very bothersome. So I would definitely think about a switch.
Yeah, and I participate in the developing of an NTRK drug called larotrectinib. That is the competition of entrectinib. Entrectinib works for ROS, but also works for NTRK. Yes, these NTRK inhibitors, not the ROS one, the NTRK inhibitors, in this case, entrectinib, that's both. You can have there is a number of fractures reported. That was very interesting because, it's something that was unexpected, that we had to collect data, even in kids, when we developed the NTRK drugs, so that you can say, oh yeah, a senior person, 80-year-old, gets a fracture, anybody gets a fracture at 80-year-old. But even in youngsters and kids that we treated with larotrectinib and entrectinib, there are reports of bone fractures. Yeah, that very, very rare. I think it's close to 1%. It's spontaneous bone fractures, but this doesn't happen with the ROS1 agents that we use now. Of course, we had to get more data with taletrectinib. It just was approved, and keep looking for that. But usually it's the NTRK agents. So that's why I agree with Dr. Dietrich. Hopefully, we don't have to worry about this anymore. But anyway, it's more than 20 minutes already. We want to give you thanks to our panelists for presenting this evening and leaving this meaningful information. And of course, we want to give thanks to Nuvation Bio for the sponsorship, GoTo for lung cancer, and the ROS1 DERS. Yeah, we want to give hi to Janet Freeman, from the ROS1 DERS. They do an amazing job. We're very proud of what you do. And all of our doctors we're here for you guys whenever you need anything from us. Unfortunately, they couldn't come tonight, but we know that they are there working very hard with us. And then I want to also give thanks to FLASCO for putting together this seminar, and we will try to keep doing more of this to try to empower our patients and educate everybody. Thank you very much, and have a good night, everybody.
Pleasure. Thank you so much.
Thank you all. Have a great night.